Well, welcome everyone to our Fireside Chat. We are the Africa Healthcare Network, and we love to host these Fireside Chats every week. We meet together, and we have the honor of hosting a speaker today. Her name is Dr. Smriti Khanna, and she is currently based in India. She'll be talking to us today about the goals of kidney supportive care. And we would like to take this chance to share a little bit more about her. She's a consultant in pain and palliative care at the PD Hinduja Hospital and Medical Research Center since 2023. Before this, she served as a consultant in the palliative and supportive care unit in a hospital also in Mumbai from 2019 to 2023. Her medical training includes a medical doctor in general medicine, MRCP, and an MS in palliative medicine from Cardiff University. She's completed recently specialized training, which is the EPIC training, Education in Palliative Care and End of Life, and participated in a professional development workshop as a master facilitator in palliative care. With 2 years of experience in pediatric hematology, oncology, and 5 years of palliative medicine, she's highly skilled and knowledgeable in her field, and she serves as a faculty in a variety of pediatric and adult palliative care programs, including 2 World Cancer Pediatric Palliative Care Fellowship for South Asia, the India Academy for Pediatrics, Pediatric Palliative Care Basic and Advanced courses, as well as the International Neuro Palliative Care Fellowship. She has a special interest in encompassing renal palliative care, pediatric palliative care, and medical ethics. She's dedicated to improving the quality of life of her patients and contributing to the advancement of palliative care. So we're really honored. I had the privilege of meeting Dr. Smriti last year and have stayed well connected. She's been actively involved in supporting our team at AHN to grow the supportive care program for our patients in Kenya, Tanzania, and Rwanda. And we're really excited that you're with us today. So without further ado, we'd pass it over to you, Dr. Smriti, and yeah, really looking forward to hearing your discussion.
Thanks a lot for that lovely introduction, Helen. Thank you, the African Healthcare Network, for having me here. I'm sorry to hear that some of you in Kenya are having a lot of trouble with the rains, but I hope that we can just have this exciting session about renal palliative care and the goals of care involved in renal supportive care or kidney supportive care, as it's known. I'm just going to go ahead and start sharing screen, and then we can start. So the topic for today is the goals of kidney supportive care. And I was told that we are usually doing a lot of case-based discussion, so I thought let's start with the case, and then we can go on to exactly what kidney supportive care is and what all does it entail. So this is actually a gentleman that I had recently taken care of a few months ago. He's a 75-year-old male gentleman, a surgeon by profession. He was a general surgeon. He had interstitial lung disease diagnosed 10 years, probably somewhere around the age of 65. But his disease was more or less stable, and he was doing well till the COVID-19 pandemic hit. And he had COVID in 2022. Since then, his lung functions worsened. He had been on domiciliary oxygen for the last 2 years, had to stop practice because he was predominantly homebound. He also was diagnosed with chronic kidney disease 5 years prior to presentation, and the last year of his life had been on hemodialysis. He had a permacath. He did not have a functioning fistula. Now, in the last 6 months before coming to hospital, there was a lot of worsening mobility. He needed to go to he needed to go for his dialysis by ambulance because ambulation wasn't that good for him, and the family was thinking about whether he could have home dialysis because travel was becoming so difficult, such a task. So how their family situation was that they were a husband and wife living in Mumbai. That's the financial capital of India, and it's somewhere in the west of India. And they had a son who lived with his family in Delhi. Delhi is the capital of of India, and is in North India. So Mumbai to Delhi is about 3 hours by flight. Because husband and wife had an active kind of life, everything was all right. But since he had become homebound, at one of his visits to the pulmonologist, he had said that he felt depressed. He had explicitly stated that he never ever wanted to be on the ventilator. He was depressed because he had to stop practice, and he was very upset with having had to start dialysis because he felt that it was because of dialysis that his quality of life had gotten worsened. And so he would repeatedly tell his nephrologists that he wanted to stop dialysis. Now, let's stop the case here and think about what we can do for a patient who would want to stop dialysis. And before we come to that, we have to look at a few definitions, one of which is the topic of this lecture today. So first comes the definition of kidney supportive care. Kidney supportive care includes interventions which are done in order to improve the quality of life of patients with kidney disease. And as you can see, kidney supportive care actually includes a gamut of interventions. So there is symptom management there. There is expert communication in which you have discussing prognosis, which is not something that we always end up doing with our patients. We have shared decision making, and we have advanced care planning. We'll come to each of these as the lecture goes forward. One other aspect of kidney supportive care is the interdisciplinary team supports. That just shows us exactly how many people are involved in the care of a patient with chronic kidney disease. So there will be the nephrologist, the palliative care specialist, the nurse, the dietitian. Some institutions or some countries have a chaplain, not all do. There would be the social worker. There could also be the psychologist, the physiotherapist. All of these form part of the interdisciplinary team. And then the other aspect of kidney supportive care is giving patients the option of comprehensive conservative care, which we will be discussing a lot in the next slide. And there is also end-of-life care, which is care which maximizes dignity towards the end of life, and also includes bereavement support, that is support after a patient dies. So this is what kidney supportive care is. Now we come to the next definition, which is comprehensive conservative care. This was actually laid down in the last few years. I think it was the 2015 KDIGO guidelines that spoke about comprehensive conservative care and actually put down a definition for it. So it is a holistic patient-centered care for patients with stage 5 CKD that includes interventions that will delay the progression of kidney disease. And it includes all these aspects, which is shared decision-making about goals of care and about the treatment plan going forward. It includes active symptom management, detailed communication, psychosocial support, family support, and also the cultural and spiritual domains of care. So that's your holistic patient-centered care included over there. It's important to note that comprehensive conservative care does not include dialysis. And then we have another definition, which a lot of us in low to medium income countries would be familiar with what this definition entails. So there is choice restricted conservative care, which is conservative care for patients in whom resource constraints prevent or limit access to renal replacement therapy. So you cannot say that this patient is choosing conservative care by choice. It's almost as if he has to do it because he does not have any option. He does not have any option with him. I think all of us have seen enough patients like this, patients who come from poor resource settings, who come from far away, who come from areas where they cannot access dialysis, who are the chief breadwinners, and therefore if they go on to dialysis, that means the family will not feed. They have a lot of people depending on them. And so if these patients end up not going on dialysis, we would call it choice restricted conservative care. So we also, we had also discussed about who will need kidney supportive care. If you remember, kidney supportive care was any intervention that improves the quality of life of patients with kidney disease. So kidney supportive care would be the conservative or non-dialysis patient group. Pre-dialysis or those undergoing dialysis with a high symptom burden that impacts on quality of life. Other coexisting organ failures, so patients who have other coexisting organ failures. Those considering withdrawal of dialysis, and those with a dual diagnosis of cancer and ESKD. So pretty much you have most sick patients with chronic kidney disease will benefit or can benefit from kidney supportive care. So I think what I'm trying to say here is that the old model in which, okay, once you have chronic kidney disease stage 5, either you go for dialysis or you go for transplant is now being replaced by the new model where comprehensive conservative care is an option that is mandatorily required to be given along with the options of dialysis and transplant. And a lot of the renal guidelines now speak to this. So getting back to our patient with ILD and with CKD and having difficult ambulation and having to go to hemodialysis in the ambulance, the family decided that they would continue dialysis. They coaxed him and they convinced him in some way or the other. A few weeks later, he was admitted to the hospital with CRBSI. He had foam cap-related infection and shock. After a few days of admission into the hospital, he had worsening sensorium and he developed meningitis. CSF showed a frank meningitis picture. He needed prolonged antibiotics. He, because of the poor sensorium, poor GCS, he also had to be ventilated for 1 week. And even after extubation, GCS was poor, sensorium was still poor. Now, at the end of 6 weeks of antibiotics, he went home considerably worse than how he had come. He was bedbound. He needed constant round-the-clock nursing care. He was on RT feeds. He wasn't able to feed by himself. And the family instituted home dialysis for him because it was very difficult to move. This admission was actually the point of time when I was involved. The reason that I was involved was because the family wanted to discuss different options. In this admission also, they discussed stopping dialysis and discontinuing most aggressive treatment because they knew their father and they knew that this is not things that he would have wanted for himself. This was especially true when they had to put him on ventilator. And once he got a little better and got off the ventilator, there were different options that they were considering for transfer, for home care at home. And so I was discussing all these things with them. So this gentleman now has gone home on home dialysis. And considering his situation, considering the age and the multiple comorbidities that he has, let's think about dialysis, which is usually something that we offer perforce to most of our patients. But is there a subset of patients in which it may do more help than harm? And I'm going to show some data to sort of substantiate all these statements that I'm making. Patients with high comorbidity scores, that is multiple comorbidities, may not have a survival advantage with dialysis as compared to a non-dialysis pathway. And in these patients, their hospital-free survival becomes similar for both dialysis and non-dialysis groups. In older ages, dialysis has been associated with a loss of independence. And the quality of life and the survival of dialysis patients more than 60 years is actually similar to that of patients with a terminal malignancy. So these are quite shocking statements, which even when I read them first, I was quite taken aback to read these. But let me show you some graphs and some statistics. So what I had spoken about a higher age group having a lot of mortality from ESRD and from dialysis becomes evident here, because you see that in the 80 plus and even in the 70 plus age group, mortality from ESRD and dialysis is more than cancer or diabetes or heart disease or cerebrovascular disease. And so this is something which is which is quite ominous. And this goes to show that this is a graph of patients who were needing assistance or needing to be supported as dialysis went on. And you see that as the years go by or as the months go by, the number of patients who require assistance or who require support increases, and the number of patients who were independent more or less goes down. And all this is primarily for patients in the older age group. So this study was done on patients at 80 years of age or older, and this one was done on patients over 75 years. There are two interesting survival curves here. They compare dialysis and the conservative pathway for patients with no or less comorbidities versus patients with more comorbidities. So this one is patients with no comorbidities, and you can see a straight up survival benefit for those who have gone on to take dialysis. But this is for those with a high comorbidity. This would mean 2 or more comorbidities. And you can see that there is hardly any survival benefit between the dialysis and the conservative pathway. So that means that irrespective of whether they chose dialysis or not, their lifespan was pretty much the same. And in this study, they realized that especially those with ischemic heart disease had high comorbidity scores and had poor chance of survival. So I've shown you some data, but what about concrete guidelines about when should we think about withholding dialysis? When should we think about stopping dialysis? And these are guidelines from two different papers. The Renal Physician Association 2010 had released a statement, and the KDIGO position statement of 2015. So this was the executive summary of 2015. So one guideline says that it is reasonable to withhold dialysis treatment if the patient is over 75 years of age with 2 or more of the following risk factors. And risk factors include high comorbidity scores. I'll be coming to what they are in a minute. There's marked functional impairment, so performance status will be low, severe chronic malnutrition, and a response of no to the surprise question. So bear in mind, they have to be over 75 with 2 or more of these risk factors. And also, I would like to talk about what the surprise question is. Basically, the surprise question is something that a doctor asks himself when a patient enters into his consulting room. And the doctor asks himself that, would you be surprised if this patient died within the next 12 months? And if the response is no, I would not be surprised, then that means there is actually a cue to initiate palliative care. That means that the patient is probably in the last year of life, and whatever measures we need to institute for that need to be started. And this was found to be surprisingly accurate. I don't remember the exact percentages, but I think it's somewhere between 60 to 70% accuracy doctors have diagnosed this with. So that means that they have been about 60 to 70% accurate while answering the surprise question. So this is one of the sort of guidelines on when to withhold dialysis. Another one is for patients with profound neurological impairment, in the sense that they are not able to understand, sense, or feel the world around them, and there may be a lot of agitation and restlessness, and they might be pulling out tubes. So this is one subgroup of patients where we may consider withholding dialysis. Patients who have had previous advanced medical directives about not wanting to go on dialysis, or patients who have currently decision-making capacity and have made an informed choice that they do not wish to continue dialysis. And ideally, we should be making sure that they are not depressed, that there is not a very large symptom burden which is making them want to stop dialysis, or there are no financial or social factors that are making them want to stop dialysis. But I think that we also know that that kind of is the reality for quite a few of our patients, and that is exactly what choice-restricted conservative kidney management is. So these are some of the situations in which it is it is possible to withhold dialysis. It is ethically correct and medically correct to withhold dialysis. Now, what if a patient is in any of these situations, but either the doctor or the patient's family is unable to make a decision? If there is an ethical dilemma or if there is a delay in making a decision and dialysis is emergently indicated or he has to continue his regular dialysis, one option that we have in this situation is giving a time-limited one option we have in this situation is giving a time-limited trial of dialysis. Usually the time-limited trial is for a few weeks. What we say is that we will come back after a few weeks' time and then reassess, and based on how the patient feels and how the doctor sees that he is managing dialysis, we may then move on to take a decision. So this time-limited trial is actually quite a useful tool when we are having difficulties in decision. Now, I had discussed about comorbidity scores and prediction model, and previously I'd also discussed about the importance of prognostication in ESRD patients. It's important for us to prognosticate, especially in elderly patients, because their physiology is very different. The perturbations in physiology will be a lot more when they get initiated on dialysis. Their mortality, their morbidity, their quality of life, all of this takes a hit. And so it's important for us as physicians and as nephrologists to make sure that we are able to give the right information to them. So this is a prediction model. The modified Charleston score is one of the comorbidity scores that can be used to decide if it is reasonable to withhold dialysis treatment. There are a few others also, and there are some hemodialysis mortality predictors that I have put in on this slide too. So these are some of the prognostic indicators that we can use. So now coming back to our patient. If you remember, he was admitted with sepsis and then meningitis. And at the end of 6 weeks, once he had finished his course of antibiotics, poor GCS still, went home bedbound, family kept a nurse, required 24/7 nursing support, RT feeds, not able to take orally, and on coke dialysis. 3 weeks later, he was again readmitted with aspiration pneumonia. The son was already with him in the previous admission for 6 weeks, was on the verge of losing his job, went back to Delhi for his job, and then again came back and had to leave his job finally. But this time when he was admitted, just on the second day of admission, I met his wife and she spoke about how he had a very poor quality of life. He was very depressed. He was not able to eat orally and had to just be fed on the RT, and that was also adding to his discomfort, his distress. He would just speak a few sentences. And she said that this is not the quality of life that he would have wanted. I don't want to continue aggressive measures anymore. So now at this point of time, we have another sort of question to discuss, that how do we go about this? How do we ensure that this is actually what he wanted? How do we ensure that the family knows what he wanted? And how do we go about making the right decision for him? So this is what a goals of care conversation or conversations can entail. Usually by the end of goals of care conversations, what is it that we hope to achieve? We hope to make sure that the family understands the prognosis and the trajectory of the illness. We hope to elicit preferences, most commonly of the patient, but if not possible, then from the family. We hope to know what their resuscitation orders are, what their code status is, do they want CPR or not. We hope for what their thoughts about critical care or intensive care are, whether they would want themselves or their loved one to go through that. What are their thoughts about the use of invasive and non-invasive diagnostic tests or treatments, so ventilators, hemodialysis, vasopressors, surgery, blood products, antibiotics, nutrition, any and all life-supporting measures, basically. We want to assure them of our approach towards symptom management and comfort, irrespective of whatever else we are going to be doing, irrespective of whether treatment is directed at cure or at comfort. And we want to discuss and hope that they understand what are our discharge and transfer options, including transfer to home-based care, transfer to hospice, or continued hospitalization. So this is all that we hope to achieve in our goals of care conversation. And it's not necessary that we would end up achieving all these in one conversation only. We may require repeated conversations. And at one point of time, we might only use the goals of care conversation to ascertain what is immediately important for that moment. Like, for example, in a situation where a patient is in casualty or emergency and may need the ventilator, we could just have a goals of care conversation about that and have a discussion about the rest later. So this sounds very daunting, isn't it? Goals of care discussions. I think I'm having some questions in the chat. So this sounds very daunting, isn't it? That there are a lot of things to be achieved here when I talk about the goals of care discussions. And there are a lot of barriers also. So there are some physician factors which because of which we avoid talking about it. There are patient factors and there are other factors also. So physicians are also scared about causing distress to the patient and the family. They're distressed about, they are worried about reducing hope for them, and worried that if they reduce hope, they may not take treatment, they may not be compliant, they may stop coming to the hospital. Another reason is that we have many times personal discomfort with discussing things around death and dying. We don't have training. We don't get taught these in medical school about how to discuss end-of-life issues. We've hardly had mentors who have done it. We've had mentors who have inspired us throughout our medical journey, but we've hardly had mentors who have done a good goals of care discussion, and so sort of been a role model for us. And there are also some biomedical ethical issues involved, such as issues around autonomy. Who gets to decide, the patient or the family? Because we are in a culture where which is not similar, I would say, to the Western culture, where patient autonomy is prime. For us, a lot of care, a lot of health is family centered. And then there is paternalism, which is doctors feeling that they know what is best for their patients. So these are some of the physician factors which are barriers to goals of care. There are patient factors also. The family itself may be reluctant to address worsening function, to address end of life, to even talk about it, because they may feel that the patient will stop coming to hospital, stop going for dialysis. There may be social-cultural factors. It may be difficult to decide who the decision maker is for the family, for the patient. And they may not be ready for this discussion at all in the first place. There may be denial around the disease. They may not want the patient to get depressed, so to speak. The patient may not always be aware of the seriousness of his condition, and so the family would not be ready to address the goals of care. And then there are other factors. We don't have hospital-based protocols around documentation of goals of care or documentation of advanced care planning. And we don't have adequate training for this either at our undergraduate or postgraduate level. And so there are some templates and some tools that I'm now going to show in the next few slides about how we go about goals of care discussion. There are two main communication strategies that we use. One is the communication strategy around breaking bad news, and the other is the communication strategy around serious illness conversation. This goals of care will incorporate a bit of both, because we will have to incorporate some of our basic communication strategies of breaking bad news, and also having conversation around the serious illness in order to understand what their needs and preferences are. So there is the remap framework, which we say reframe, which starts with, which is basically an acronym. So R is for reframe why the status quo isn't working. So discuss the serious news and then say something like, given the serious news, this is I think that this is the time to talk about what to do now, because things are changing. We are not in the same place that we were before. Expect emotion and respond with empathy. This is one important step that we always kind of miss in our zeal to get all our information across. But studies have shown that unless unless emotion is addressed, unless it is empathized with, or unless it is named at least, it's going to be difficult for the patient to move on. It's also going to be difficult for them to absorb all the information that comes after that. So even if it is for the purposes of efficiency of your conversation, of your goals of care conversation, this is important. So use sentences like, I can see that you are upset. I can see that this is worrying news. Shall we go ahead and talk about it? Things like that. And then we map out what is important. This is an important aspect of the goals of care understanding, because this is where you are now placing the patient and the family right at the center of decision. And this is what I think in some of the earlier slides, I had used the word shared decision making. So this is where actually shared decision making comes in. Because this is where you invite the patient to talk about their preferences, their values, their ethics, their goals, their expectations from their own lives. And so you ask questions like, okay, now that we know that the situation has changed, what does this seem like for you? What is most important for you? What are the things that you would like to achieve in the future? Or what is worrying you when you think about the future? And then we come with aligning with the patient's values. So once you have allowed the patient to talk about what is important for them, what are the things that they would like to do, then come up, kind of name that, okay, I understand, and it sounds like the most important thing for you is the fact that you are able to retain your mobility, or the most important thing for you is the fact that you are able to go back to your hometown. And then you make a plan to match the values. So given the fact that you would like to go back to your hometown, this is what I would like to do. I would like to make a home care plan with you, send you home with some medications. This is what I can do to help you achieve this important bit. And what do you think about it? Now, this remap framework has actually been designed thinking about keeping it was first designed for cancer patients, but this is actually something which can be used for any serious illness. Another framework of use is the serious illness conversation guide. If you will go through this, you will find that there will be a few different points between different tools, but more or less, this is what they are coming to. The serious illness conversation guide is also like a one-page kind of guide about how you can have discussions around seriousness of illnesses and what we need to do about it. So setting up the conversation, asking permission about whether they want to talk about the problem, or would they want somebody else from the family, other people involved while talking about it. Assessing their understanding of their health, assessing their information preferences, sharing their prognosis, and some of the things that we had looked at in remap are coming here also. Exploring emotion, allowing silence, using non-verbal cues. These are all parts of communication around breaking bad news. Then we come to exploring key topics like patients' priorities, patients' fears and worries, patients' strengths, what helps them through the tough times. This means that you are actually addressing the socio-cultural, religious, the spiritual aspect of their disease and what has helped them through their disease. What are some critical abilities that they would want to retain right till the end? What are some trade-offs they are willing to make? If he says that he would want to walk, or if he says that he would want to remain ambulant, is he all right staying back in the hospital rather than going back home in order to remain ambulant? So that would be what a trade-off is. Closing the conversation by summarizing what you've heard, providing clinical recommendation, formulating a plan, just summarize the whole thing, and then document the conversation. So this is another tool that we can use. And a lot of times what they advocate is just use this as a checklist to make sure that you have gone through most of the points. Again, I'm reiterating that serious illness conversations, goals of care conversations may not all happen in one conversation only. It may be too difficult for patient or doctor to complete it all in one go. You can have multiple conversations and do chunks of these in different times. And this is also important for when you don't have enough time. And so you may have a consultation of 10 minutes only, and then you may just do the important preferences first and then follow up on the others later. There is also surrogate decision making for a non-autonomous patient. So a patient who has lost capacity, who does not have capacity, who has given away decision making to somebody else from the family. So you use either substituted judgment, where in which the family decision maker or the decision maker, whoever they are, will substitute their own judgment of what the patient would wish in the circumstances and not what the surrogate would. Then there would be the best interest standard, which is what is in the patient's best interest. And then there is, if you are not sure about the patient's best interest, there is substituted interest. So based on what you know of the patient's values and interests, what do you think would that patient's decision be? So most of the times we use the substituted judgment or the substituted interest standard, especially in goals of care conversations where the family has never had advanced care planning discussions before, not made an advanced medical directive, which is quite a common phenomenon, I think. And the patient is brought in not competent, unconscious, and it's up to the family member or the next of kin to make a decision. And so we tell them that you know this person or your loved one much more than we do. You put yourself in that situation and think what he would want based on the kind of person that he is. This is another tool that I'm sharing. It's called the Johnson's 4-box model. I know that there is another session on ethics and the medical legal issues, but I'm just sharing this because sometimes it can help in decision making, and this includes a lot more than just patient preferences or goals of care. So what the Johnson's 4-box model does is that you usually utilize this when there are ethical dilemmas or difficult medical problems to solve, wherein there is a conflict between the doctor and the patient, or a dilemma as to how to go forward between the doctor and the patient. And you see 4 boxes, and each box talks about 4 different aspects, but all 4 of them turn back to the 4 principles of biomedical ethics. So there is a box on medical indications where you will do a proper clinical analysis of the case. Then there is a box on patient preferences, which is predominantly what the patient wants and understands. There is a box on the quality of life that the patient expects and not the doctor expects that will happen. So what is the possible types of quality of life that can happen? And there is another box on contextual features, which is quite a few things that might influence the doctor in trying to make the decision. So this is something that you can use to battle paternalism, you can say, where you feel that, okay, you are making the right decision for the patient, but the patient does not agree with you. And so how do you resolve that dilemma? So this is just to show just an infographic on how palliative care or kidney supportive care can actually support a patient right throughout their illness. There is decisional support all throughout, wherein you can help the patient and the family with decision making. Advanced care planning can happen somewhere around a major health event. Social informational and emotional spiritual support also happens throughout the illness. You may need certain phases of the illness where the patient might need more psychological support, more emotional support, more informational support. Symptom control might be, the need for symptom control might be more as the disease advances. And then towards the end of life and after death is where the treatment care comes in. So back to our case, who got admitted for the second time within 2 months, the 75-year-old male with ILD and CKD, admitted now with aspiration pneumonia at the second admission. After discussion with the treating team, with the palliative care physician, the family decided for non-escalation of care. So they decided they would not escalate inotropes anymore. They would not go ahead with dialysis, no antibiotics, no blood tests, no blood transfusions. Usually we try in these patients, if it's possible for them to be moved out from ICU to the general ward or to a private room where the family can spend some time with them. But he was too sick to be moved out to ward, too sick to transport. And so the family spent some time with him at the bedside, some final prayers, holy water, those things. All that was done, and he passed away in ICU 1 day later. So to summarize, the role of the nephrologist in kidney supportive care, if I had to summarize it in one word, I would say non-abandonment. Just because your patient isn't choosing a therapeutic or a care-directed treatment option, that does not mean that there are other aspects of his illness that do not need attention. So be patient and family-centered. So focus on how to improve quality of life, focus on patient preferences, and make sure that you ascertain the goals of care. A lot of studies have shown that actually patients would prefer that their primary doctors, or the doctors that they have been seeing for the longest time, have goals of care discussion with them, and not another doctor who just comes in as on a consultatory model like the palliative care doctor does. So goals of care, if discussed by the nephrologist, can be a very effective way of making sure that you are going ahead with exactly how the patient wants his or her treatment to be. It also entails good aggressive symptom management and management of the active disease, then interdisciplinary care, as we have spoken about, shared decision-making, and advanced care planning. I haven't gone too much into advanced care planning. I wasn't actually sure. I think that Dr. Esther will be taking it because it's part of the medical legal issues, but basically advanced care planning is once you have the goals of care discussion, talking with them about if they are sick, to need intensive care or to need any kind of life supporting treatment, what aspects of life supporting treatment would they want and what would they not want. And then the most important part of it is documenting it on paper so that everybody in the healthcare team involved in their care has access to them. So another aspect is stressing on the importance of home-based care. If you have community home-based care, palliative care programs, or just home-based care, supportive care programs, or just community doctors who will be able to go and see the patient, rope them in, make sure you are able to stay in touch with the patient in that way. And supporting the patient even at the end of life. Place of death is something which not everybody has the same opinion on. Some patients, some families would prefer that their loved one dies at home. Some of them may not be able to have the support or cope up with it. And so we make a decision based on their preferences again. So that's the end of my talk. I'll leave you with this quote by Atul Gawande. And thanks a lot.
Thank you, Dr. Smriti, for taking the time to walk us through that, and especially sharing the case of your patient and their family. I know sometimes with these kinds of topics, it can be a bit heavy, yet I know that it sounds like your team spent a lot of time thinking about what to do with this patient, making sure they were prepared for what had happened. So thank you. Thank you for all the work that you did for them. And we'll definitely put it towards the group now. We have about 10 minutes. If anyone is curious about a topic that Dr. Smriti talked about today, or a patient they also feel in a bit of a dilemma about with their family, we'd love to be able to support a time of discussion now. So if you have any questions, you can put them in the Q&A or the chat. I did share a few resources that Dr. Smriti had shared on her slides. links to the websites where you could download them. One question I have, Dr. Smriti, is how do we engage with families when some of these topics are just so difficult to discuss? What are some of your tips when it does seem like a family is just really overwhelmed with the fact that potentially their loved one is not going to recover, or they're not going to live for much longer? What are some simple things that you've done in your practice when it seems too emotionally overwhelming to even talk to families or patients about their goals or their wishes?
A couple of points here. I think one is that a lot of times I allow families to talk and tell me their thoughts about how they think their patient is doing. So if I've seen them one or two times, and then the next time when I go to see them, I ask them, how do you think he is doing? Or how do you think she is doing? And then a lot of times their worries come out, and they say that I don't feel that he's going to be, he's looking much worse today than he was yesterday. And I was thinking today that we almost had a scare in the morning, and we thought that he wouldn't make it. And have that kind of that sometimes opens up a channel of discussion, which you can then take towards course of care, or you can take towards withholding or withdrawing of life supporting treatment. Another thing I found useful is talking to families once the patient has been out of a prolonged hospital stay or a bad ICU stay, and then talking to them that time about, I know you've just been through this, and you remember how it was like, what it was like. If unfortunately such a thing happens again, what would you want to do? Would you want to go back? Would you want to be put back again on the ventilator? What do you think? Because that's actually a very good point to have the discussion about goals of care. We don't always end up doing it at an opportune moment, and then once they're out of ICU is also a good time.
Yes, so really thinking about the experience in the moment. Obviously, we don't want to re-traumatize them if it was a traumatizing ICU experience, but also using the experience to grow and learn about what was important to the patient, what was important to the family. I think that's a really good idea. So in our setting in Kenya and some of our other centers, we have clinical officers and nurses that do a lot of the day-to-day care. And some of our medical officers and nephrologists see patients with a month or every 3 months. What is your advice for some of our frontline providers in terms of goals of care or thinking about values when you may not be the specialist on the team? Are there some things that our general providers can do to support families and patients in their communication?
I think patients would be more comfortable talking about with the general providers would be symptoms, things that are really distressing them. Social or financial issues that they are having. We may not have answers to all the questions that they have, but we may find ways to address some of them. Our goals of care may be oriented towards what are the social and the cultural issues that they are facing. I know from my experience of working in government hospitals in Mumbai, also, I know that there are a lot of patients who cannot opt for dialysis because they are just staying too far. It's just not feasible. There isn't enough access. There is no money. And so this is where the whole dilemma of the choice restricted kidney care comes into play. And so for these patients, it becomes very distressing for teams to take care of them, but know that there is no sense in abandoning them, even if they are going home for their end of life. There are other ways to keep them symptom free, to keep them comfortable. There is medical management that we can do, at least to make sure that they don't have pain or breathlessness or distress.
Yeah, so it's almost like a team approach, even in these situations where maybe you're not seeing the specialist all the time, using the frontline providers to give that bigger picture of what's happening, looking at their symptoms, which oftentimes can inform their decisions, right? If a patient is non-symptomatic and the quality of life is fair, maybe that would impact how they make a decision. Do you often find that you have, and please do put your questions in the chat. I know a lot of our colleagues in Kenya are having terrible power issues. So maybe some questions might come up after also. But do you find that you tend to plan more time when you have these kinds of discussions with families? And then how do you go about that when you need to spend, rather than 10 minutes, if you need to spend 20 or 30 minutes? Do your other patients then have less time with you, or do you ask them to come back?
That's a good question. I usually try and schedule first consultations with patients in a way that I have ample time to talk, because I know that the first consultation will take time and then the rest may not. So that is one way that I try to make sure that we do that. But like I said, even if we have 10 minutes, at least discussing core references, such as those of ICU or dialysis or no dialysis, or place of care, or what are the most troubling symptoms that are distressing them. So knowing, once you just assess a case, you know exactly what are the 2 or 3 things which are troubling that patient or that family the most, and then just focusing on that, and not, even if you are not able to do all of them together, all of the others together. That's, I think, how you end up doing it in a setting where you don't have enough time to do a full assessment maybe for each patient.
And then when you do that assessment in your setting, at AHN, we have paper-based charting as well as a electronic medical chart. How do you, at least at AHN, we have small clinics all over, and each of our partners also sometimes has different systems for documentation. How do you find that your team is able to document, or does the family kind of take that responsibility on, or is it really based on the clinic and in the hospital or the partner?
I don't always have a comprehensive documentation, like a tick box or a check box which covers all the issues. Sometimes my documentation is about the most major or the most important issues that the patient has. Most of my, but I will ensure that I do have goals of care documented at every admission or every few OPD visits, at least with patients, so that they are, when somebody is going through the file, it will come up on top at some point or the other. So even if the patient doesn't inform them, they will see it somewhere, and then they will make it.
Because there's a chance that we may not be the ones that are providing the care in a certain moment. So even though we have had the conversation, we may not be the one that is potentially implementing it.
Exactly.
Dr. Mazar, would you like to make any comments or?
Thank you, Dr. Smriti, for your presentation. Unfortunately, for some reason, we've been having power cuts on this side as well in Tanzania. So I've been in and out of your talk, and that's why I sent an apology on the chat. But thank you very much for your talk, for whatever I could hear when I was in and out. And I think, as you correctly said while you were presenting, that during our training as medical professionals, we don't get enough training on how to do this particular aspect of patient care. We're very clinical oriented. We are very, I must say, fixing everything kind of, the hero kind of thing that, you come to me sick and I'll sort you out kind of thing. And during my early days as a clinician, I was of that impression that a patient comes to me for help, he's sick, I need to fix him and I need to get him out of the hospital. But as I kind of specialized and then subspecialized in nephrology, I came to know that there is a limitation of what we can do. We cannot solve everything. And one of my mentors, my professor, who is now retired, but he's a very well-distinguished professor, and I never used to understand him. When I was doing internal medicine residency, he used to say, listen, you need to know when to stop. And I was like, what is this guy talking about? Why? I mean, I can solve this problem. But then later on, I came to realize when I did nephrology, is that there is a time that you have to know when to stop. And it's just not nephrology, it's everything else, including other, I wouldn't say terminal illnesses, but illnesses that would impoverish someone, or illnesses that would take a toll on the patient, with poor quality of life, or take a toll on the family. So you need to kind of know, okay, where do you stop? How do you make this patient comfortable? What do you do kind of respect the patient's requests or the family's requests, or take it in a holistic nature. And I must say, since we've started this kidney supportive care program, slowly but steadily, things are kind of, falling into place. Obviously, my mindset had already changed during that time, but I feel like now the boxes are aligning and things are kind of falling in place. And hopefully, as we go on, perhaps, I'll probably gain a few more insights into how to kind of deal with these patients. And, because at the end of the day, you want to respect the decision, but now the question is, how do you, kind of take that discussion and make it in such a way that you're not giving up, you are there for them to support them. But it's very important to know how to speak what you would like to speak, so that they understand that you're not letting them go, you're not giving them up, and you are there to take care of them. So again, thank you very much, Erin. Thank you very much, Dr. Smriti. I think we are still a long way to go, especially in Tanzania, where we have some sort of supportive care, but it's not fully, out there. And I think slow but steady, I think we're making baby steps and we'll get there. Thank you so much.
Thanks, Dr. Mazar. I think some of the, Dr. Smriti, there's a few questions that have come in the chat, so we can answer them and then we'll close for today. But Dr. Mazar, I think it's very similar to any of your medical training, or I know we have nurses on the call today. It comes with practice, and it's not easy, even for providers, to do this. So I really honor you for sticking with this, for attending some of these sessions, and then also encourage people that maybe have been hearing about supportive care for the first time. The first few times that you do it, it will feel awkward, very similar to the first few times you inserted an IV or you gave an injection, or, I mean, we probably don't remember those because that was years and years ago, but that's the same mentality we have to have. You will get better with practice. Of course, it's a very different skill, but just really encouraging that you try it. Anyways, okay, so Dr. Smriti, there's some interesting questions here about nutritional considerations for patients at home who have renal disease. Leonard from Kenya says they do community palliative care. So do you have any thoughts on that? I know there's a lot of advice. We have a nutrition team at AHN that really supports us, but any initial thoughts on supportive care in terms of diet?
Yeah, thanks, Erin. I can tell you a few. I can tell you a few practical points that we do, Leonard. I'm not very sure about the diet in Kenya, but the diet in India is most patients that I see have a predominantly vegetarian diet. There is very little non-vegetarian food that is incorporated. And so as a result, they are already in a diet that is protein deficient. So we don't usually ask them to restrict their proteins, especially if they are on dialysis. So that would be one thing that I would be thinking of. For me, diet restrictions or diet discussions would primarily be around electrolytes for these patients. So just avoiding potassium-rich, foods and fruits and things like that. The other thing is that towards the end of life, I omit all restrictions completely. So fruits that they would like, juices that they would like, things that they wish to taste, which they haven't before. A lot of these patients are diabetic and may have restrictions on sugars. So I would most likely omit most of them. Also, another thing is that for your patients on insulin, at least for me, in the last few weeks to months of life, my sugar levels or my glucose targets will be much more relaxed than usual. So if you were usually targeting something like 100 to 120 towards the last few weeks or months of life, I would be targeting 200 to 250. That would be my, even up to 280, I think. That would be my that would be my sugar levels. So that's about nutrition. And then how do you, there is a question from Leah, how do you support a patient who feels that the family is never doing enough, despite the family members reporting that they are offering the best that they can? Patient is at the end of life. It seems to me, Leah, that this patient is in a lot of either emotional distress or spiritual distress. There is a whole lot going on behind this this statement. And that's going to require a lot of digging deep. And I would say that rather than focusing on family members, we would end up having to focus much more on the patient in this case. If you have the services of a psychologist or a counselor or a social worker, use those. If you don't have, the best thing I think that you can do is just sit and talk to this patient. Just sit and listen, and eventually they will speak and they will get to the bottom of whatever it is that is troubling them. There is going to be some other spiritual or psychological distress under this. And sometimes it's just enough that it comes out, because most of the times we don't have answers, we don't have solutions, but it's always enough that a lot of the times it's just enough that we listen.
Yeah, I wonder if in the situation we could even offer like separate meetings, one with the family, one with the patient, seeing if some of these individual discussions could bring up anything, and then, you know, potentially bringing them together. Not that we're moderators, but sometimes based on the type of relationship we have with the patient and family, they do trust us. Then potentially allowing for a safe space for everyone to talk. Again, if you do have access to a counselor or a trained psychologist, it's probably better, but sometimes we are the option, the frontline providers, the person that sees the distress in the patient, wants to offer some solutions and some support.
Another option is would be offering hospice care.
Right.
If the patient and the family both feel that it is not a good fit, or if the patient is actually expressing a desire to not want to be with the family, then if you have access to hospice care or institution in which the patient can stay, that would be another option to explore.
Yeah, in a lot of our settings, we may not have a lot of inpatient hospice care, but potentially community-based, where some extra support could be needed, some extra emotional support, maybe, again, not necessarily saying what are the reasons that you feel this way, but just being there, really supporting the family and the patient during that time. All right, well, thank you. Thank you, Dr. Smriti, so much. Joanna also put in the chat that kidney supportive care is not really advanced in her country, and is very interested. So I just wanted to let you all know that we do, during these fireside chats, they happen actually every week at the same time. We've been slotted once a month for kidney supportive care topics. So yeah, really interested if you're able to come. It's the first Thursday of every month that we do a kidney supportive care topic. So we would love for you to be there. And again, please invite your colleagues. This is obviously a free kind of area where we are gathering together. If you do want to reach out to me, I do have an email at AHN, and I currently am the supportive care lead for our programs here. So my email is supportivecare@Africa Healthcare Network. So please do reach out. Thank you again, Dr. Smriti. It's really nice to see you, of course, as a friend, but also as a professional. It's great to see you, and thanks for supporting our program here in East Africa.
Thanks a lot. It was a great meeting on you.